So hello guys, welcome to the new video where we will discuss today about bronchial asthma. So starting with the basic, what is bronchial asthma? So bronchial asthma is basically contraction of bronchial muscles. Okay, contraction of bronchial muscles which causes impaired airflow to the lungs contraction of bronchial muscle which causes impaired airflow to the lungs, and further it causes increase in the bronchial mucus secretion and swelling of bronchial mucosa. Okay, so what will be the full definition? Contraction of bronchial muscles which causes impaired airflow to the lungs. Further, it causes increase in the bronchial mucus secretion and swelling of the bronchial mucosa. Now, going ahead with the process. Okay, the basic, like what we will say, the pathogenesis, and this will help us to remember the name of the drugs. So this is basically a story. So let me just draw one. Okay, what is this? This is the mast cell. Okay, and this Y-shaped structure are its receptors. Okay, not receptors, basically IgE. Okay, these are the IgE. Okay, now these are present near the lungs in the bronchus. Okay, now what happens is when there is introduction of pollens. Okay, now let me just draw the pollens. Okay, we know that majority cause of bronchial asthma is due to hypersensitivity reaction. So when there is introduction of pollen, what happens is it binds to this IgE receptors or Ig antibodies and then to the mast cell. So what does this mast cell do? This mast cell releases inflammatory mediators. Okay, now what are these inflammatory mediators? Remember INL. Okay, I is interleukin. Which interleukin? 4, interleukin 5. And what is L? L is leukotrienes. Okay, and leukotrienes, which leukotrienes? So they are LTB4, LTC4, LTD4. Okay, LTB4, LTC4, LTD4. These are the leukotrienes, and the interleukins are interleukin 5 and interleukin 4. Now, what does this interleukins do? So let me just draw one line for the functions of the interleukin and the functions of leukotriene. This interleukin, they causes eosinophilic activation. Remember interleukin 5, IgE, eosinophilic activation. Okay, And this, what does this eosinophilic activation do? It causes inflammation. Okay, now what does this leukotrienes do? Leukotrienes act on leukotriene receptors. Okay, LT1 receptor. Okay, and what does it causes? It causes bronchoconstriction. Okay, bronchoconstriction means abnormal bronchospasms. Yes, and also eosinophilic activation will cause inflammation. Okay, and this LT1 receptor are present on bronchus. Now, to summarize this story, what will happen when a person is walking in a garden or somewhat like near the flowers? So the pollens will come, it will go via the nasal tract to the bronchus. Now there are mast cells there. What does this mast cells do? They have IgE on their surface. This IgE will catch up this pollen. Now what happens? The mast cell is activated. The mast cell will release the mediators. Which mediators? Inflammatory mediators. This inflammatory mediators are I and L. So I is interleukins and L is leukotrienes. Which interleukins? Interleukin 4 and 5. And which leukotrienes? LTB4, LTC4, LTD4. What will this interleukins do? This interleukins will basically causes eosinophilic activation. Remember, when you see interleukin 5, you should remember the fifth alphabet. Fifth alphabet is E. Yes, so eosinophilic activation. Okay, and in leukotrienes, it acts on the leukotriene receptor which are present on the bronchus, and they will cause bronchoconstriction. Now, keep this story in mind. We will come to this story a bit later. Now, the classes. The classes of the drugs. Remember, we have two attacks, an acute attack and a chronic attack. Okay, so the mnemonic for acute attack goes as Batman. BAT and MAN. Okay, now from B, what does B stands for? Yes, the very most common beta 2 agonists. And we know that beta 2 is present where? Beta 2 is present on smooth muscle, liver and skeletal muscles. Okay, now A for anticholinergics. Okay, then we have T for theophylline. And what is from M is MgSO4. Just try to remember this mnemonic first. We will go back to that story. Now for chronic, we have M lol CM. Okay, M low CM, M low LCM. Okay, or M lol CM. Now here comes the drugs which are related to this story corely. Okay, M for mast cell stabilizers, L for LOX inhibitors. I will come to this LOX inhibitors. Then from another L we have leukotriene receptor antagonist. From C we have corticosteroids, and from M we have monoclonal antibodies. Okay, now we know that from beta 2 agonist is basically relaxes the bronchial muscles, the mechanism of action. Okay, anticholinergic, same mechanism. it relaxes the bronchial muscles. Then theophylline MgSO4 we will study. Then mast cell stabilizer. What will mast cell stabilizer do? Basically it reduces the release of inflammatory mediators. Okay, then we have the LOX inhibitors. Okay, what are the LOX inhibitors? So now this leukotrienes, okay, when the mast cell is activated and it releases the inflammatory mediators, this inflammatory mediators includes the leukotrienes. Now this leukotrienes, it is synthesized by one enzyme which contains this LOX. Okay, so if we inhibit this LOX, leukotrienes will be not formed or less formed, and therefore this will act on the leukotriene receptors at a very small scale, and therefore we will see decreased bronchial constriction. Now coming to this leukotriene receptor antagonist. Now as we know that the LTB4, LTC4 and LTD4, leukotriene B4, leukotriene C4, leukotriene D4, it will act on the leukotriene receptors and then it will cause bronchoconstriction. So if we block the leukotriene receptors itself, bronchoconstriction will be not caused. Then we have corticosteroid. This is the most important, okay, and the most potent and the drug of choice for bronchial asthma. It acts by each mechanism of action. Okay, now what about the monoclonal antibodies? Do you see this IgE? Okay, the monoclonal antibodies, basically it will inhibit this IgE. Okay, the antibodies. Okay, now these are the classes in acute and chronic attack. In acute attack we have beta 2 agonist, we have anticholinergic, we have theophylline, and we have MgSO4. While in chronic attack we have mast cell stabilizer, we have LOX inhibitor, we have leukotriene receptor antagonist, we have corticosteroid, and lastly monoclonal antibodies. Now starting with beta 2 agonists. Okay, so what is the mechanism of action of beta 2 agonist? Basically it is a GPCR enzyme, GPCR. Okay, let me just mention it in this bracket. It is happening, just a second. It is GPCR, GS type. Okay, now if it is a GPCR, what will happen? It is that 7 serpentine something. Okay, GPCR. So it will basically, it will activate the adenylyl cyclase, which will further increases the adenosine monophosphate pathway and cause bronchodilation. As simple as that. And one additional effect, it increases mucus production. Okay, now further classifying beta 2 agonists, we have two types of beta 2 agonist. As other drugs, they are also classified as specific and non-specific because it is a receptor mediated. Specific sorry, non-specific. Okay, under specific we have three more classes. Okay, I will just write the short form of these classes: SABA, LABA and ultra LABA. Okay, SABA, LABA, ultra LABA. What is SABA? SABA is short acting beta 2 agonist, LABA is long acting beta 2 agonist, and ultra LABA is ultra long acting beta 2 agonist. And under non-specific we have adrenaline, we have ephedrine, and we have isoprenaline. Now we have written this. Now that we have written this drug, adrenaline acts on alpha and beta, ephedrine acts on alpha and beta, all receptors, and isoprenaline beta 1, beta 2, beta 3. Okay. So what is the mechanism of action? It activates the adenylyl cyclase pathway, which increases the adenosine monophosphate, which causes bronchodilation. Then what are the classification, or what are the additional effect? Increase mucus production. Now classification is of two types: specific, non-specific. Specific is further classified as SABA, LABA, ultra LABA, and non-specific is further classified, or the drugs under non-specific is adrenaline, ephedrine, isoprenaline. Adrenaline and ephedrine acts on alpha and beta all receptors, and on isoprenaline acts only on all the beta receptors. Okay, this was the classification. Now just adding to this, in specific beta 2 agonist, SABA. SABA is basically shorter in onset of action, okay, and shorter in the duration. So what will be the graph? Roughly shorter in onset and shorter in duration of action. LABA is slow in onset. So slow in onset, and it is long in duration of action. Okay. Now what is ultra LABA? Ultra LABA is very slow in onset, and the duration of action is more. What is the difference between LABA and ultra LABA? So basically LABA has 12 hours effect, ultra LABA has nearly double the effect, 24 hours effect. And under SABA we see the drugs namely salbutamol, terbutaline. In LABA we see salmeterol and balmbuterol. And ultra LABA we have indocterol, we have vilanterol. Okay. Now we have one drug which we hear, formoterol. It is a special drug. Okay. Note formoterol. Formoterol is basically, just a second, it is a SABA plus LABA. Okay. So basically the graph will be, it is faster in onset and it is duration of action is more. Okay, because it is a SABA and a LABA, formoterol. Now what will be the routes of administration? Routes of administration are by inhalational route. Okay, inhalational is the preferred route of choice with the MDI. We have sometimes oral route too. We have subcutaneous injection of terbutaline. And we have IV injections of salmeterol. Okay, what are the adverse effects? These are very, very, very important. So the mnemonic goes H, 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 T, T. Okay, so hyperglycemia, first side effect, first adverse effect. So why hyperglycemia? As beta 2 is stimulated on pancreas, on liver, sorry. So glycogenolysis. Okay, then we have hypoxia. Why hypoxia? Due to the ventilation perfusion mismatch. Okay, then we have hypokalemia, decrease in the potassium level. Okay, why? Because beta 2 is stimulated, and beta 2 causes more intake of, or the more movement of potassium in the muscles. Okay, TT, what is TT? T is tachycardia. Okay, because heart also has some beta 2 receptor, mainly beta 1, but some beta 2 are present on heart also. Okay, and tremors. Why tremors? Remember the mnemonic for beta 2 receptors. What was it? SLS. Okay, SLS. S stands for smooth muscle, L for liver, S for skeletal muscle. Now that we have covered smooth muscles, we have covered liver hyperglycemia. We have the third S, which is skeletal muscles. So it will act on skeletal muscle and it will cause tremors. So what is the mnemonic? HHHTT. Now let's revise. We have in beta 2 agonist the mechanism of action. It activates the adenylyl cyclase pathway, then the AMP is increased, adenosine monophosphate, therefore we observe bronchodilation. Then the additional effect is increased mucus secretion. What is the classification of beta 2 agonist? Specific, non-specific. Under specific we see LABA, SABA and ultra LABA, and in non-specific we see the drugs adrenaline, then isoprenaline, then ephedrine. Now the SABA is the shorter in onset and shorter in duration of action. LABA is longer in onset and longer in its duration of action. Ultra LABA is also the same. It is longer in duration and longer in onset. But 12 hours for LABA and ultra LABA is 24 hours effective. Under SABA we see salmeterol and terbinafine. Under LABA we see salmeterol and bambutol. Under ultra LABA we see inducterol, vilanterol. In non-specific we have seen the drugs, the effects. And formoterol is basically SABA plus LABA, in which we see shorter onset of action and longer duration of action. In routes, we have inhalational route, we have oral route, we have subcutaneous terbinafine injection and intravenous salmeterol injection. Adverse effects are HHHT, hyperglycemia due to beta 2 on liver. Then we have hypokalemia due to beta 2 on muscles, which increases the movement of potassium in the muscles. We have hypoxia due to ventilation perfusion mismatch. We have tachycardia because some beta 2 receptor are present on heart, majorly beta 1. Then we have tremors, which acts on the skeletal muscles, which tremors because beta 2 is present on skeletal muscle. So the beta 2 agonist acts on the skeletal muscle and tremors are caused. So this was all about the beta 2 agonist. Now starting about anticholinergics. Anticholinergics, the mechanism of action. What will be the mechanisms of anticholinergic? It will block the actions of acetylcholine, which will cause bronchodilation. Now the roots. Sorry, what is happening? Okay, the roots is inhalational. Okay, by a MDI. The names of the drugs remember one mnemonic, Times of India, TOI. What will be the name of the drugs? It will be tiotropium, oxytropium, and we have the drug of choice, ipratropium. So the onset of duration is more and the duration of action is less of these drugs. And that's it for these drugs. Nothing much more we will study in ANS, okay, about this anticholinergic in great depth. Now coming to theophylline. So what is the mechanism of action of theophylline? Basically mechanism of action is of theophylline is increase CAMP pathway. Okay, CAMP. So the CAMP pathway will be increased, so the bronchodilation will be increased. Okay, we have seen in beta 2 agonist the adenylyl cyclase pathways increase, so CAMP pathway is increased, then bronchodilation is caused, so the CAMP pathway is additionally increased. Okay, so under theophylline we have only this much information, and route is inhalational. Okay, but preferred route is intravenous. Okay, and also we have one preparation which is used for management, which is very much important. It is aminophylline. Okay, aminophylline is an important name. It is given IV in management of asthma. Okay, so that was about theophylline. One thing to be added, it increases the CAMP pathway by inhibiting the phosphodiesterase enzyme inhibitor. Okay, so CAMP pathway is increased, and this completes theophylline. So for chronic attack we should only remember the names. So in mast cell stabilizer we will see the word chrome in the drugs. So sodium chromoglycate. Okay, in LOX inhibitors we have the drug Xilioton. Okay, Xilioton. In LT1 antagonist or leukotriene receptor antagonist we have the drug zafirleucast, monteleucast. Okay, zafirleucast and monteleucast, where monteleucast is given commonly. Okay, and in monoclonal antibodies we have one good drug which is used everywhere, omalizumab. Okay, now going further with corticosteroids. Corticosteroids are further classified for the treatment of asthma. What is this happening today? Actually, sorry for this bad handwriting. So basically, just a second. So they are classified as systemic and inhalational. Now, what are the systemic corticosteroids? We have hydrocortisone injection. Okay, we have prednisolone tablets. Okay, we have methylprednisolone tablets. And in inhalational we have budesonide. we have fluticasone, we have flunisolide, we have beclamethasone. Okay, what the drugs we have in corticosteroids? We have inhalational corticosteroid and systemic. Under systemic we have hydrocortisone, prednisolone and methylprednisolone. Under inhalational we have beclamethasone, then we have fluticasone, then we have budesonide, and we have flunisolide. Okay, now coming to the main thing of corticosteroid, the mechanism of action. So everybody will think that the mechanism of action will be bronchodilation, but this is not the case in of corticosteroid. Corticosteroid doesn't causes bronchodilation. They basically are immunosuppressive agents. Okay, corticosteroids, so they cause immunosuppressive effect. So what happens is, the main mechanism of action is decrease in inflammatory mediators. This is the main mechanism of action. So what will be cause? Number one, decrease in hypersensitivity. Okay. Number two, decrease in the mucosal edema. Okay, and also the antibody antigen reaction will be decreased. All are anti-inflammatory effect. Okay, now this was all about the mechanism of action. What are the routes? As I have mentioned stating the drugs earlier, tablets, we have prednisolone tablets, then we have MDI or inhalational corticosteroid, we have budesonide, then we have fluticasone, and etc etc. Okay, now the main side effect, BM suppression or bone marrow suppression is the main side effect. Okay, so this was all about the drugs, and what we have studied till now. We have studied the basic pathology of bronchial asthma, then we studied the classes of the drugs, we studied the classes individually. Okay, so this was all about the classes of the drugs. Now we will see the management. So now coming to the management of patient with bronchial asthma. So suppose there's a patient, okay, visiting first time to your clinic. He is suffering from acute bronchial asthma. Okay, so for acute condition, what were the drugs? Batman, beta 2 agonist, then we had the sorry, for acute attacks we had the drugs anticholinergics, then theophylline, then MgSO4. Okay, so now if the patient is coming first to a clinic for acute attack, what will we give to the patient? So according to the GINA guidelines, first time attack we give formoterol plus budesonide. And what are the classes of these drugs? Yes, formoterol is SABA plus LABA, and what about budesonide? Is it inhalational corticosteroid. Okay, so first time if it comes to your clinic or acute attack, we give formoterol and budesonide. Now if the case worsens or not treated, this is known as a case of status asthmaticus. Though we have given the formoterol beta 2 agonist SABA plus LABA and budesonide inhalational corticosteroid, the case worsens further, we call it as status asthmaticus. So what should we do in this status asthmaticus? We give HHH therapy. Okay. HHH therapy means, first, the patient will be like he will be breathless. Okay, he will be hyperventilating. He will face hypoxia. So we will give him humidified O2. Okay. Now since he is hyperventilating, so we can't give that inhalational corticosteroid kind of thing. Okay, so we give IV. Let me just write first hydrocortisone IV injection. And what is the dose? 100 milligram stat. Okay. And now, as the patient, like he is not treated by this beta 2 agonist and ICS. So the third H stands for high dose of beta 2 agonist. Now tell me one thing. When he first came to your clinic, we gave him a SABA and LABA combined formoterol and one inhalational corticosteroid. And if it is not treated, it is known as status asthmaticus. And now what we give? We again give a SABA and LABA, and we again give a ICS. Not ICS, we give SCS, systemic corticosteroid. One systemic corticosteroid, hydrocortisone, and one high dose of beta 2 agonist. And additionally, we give humidified O2 to just treat the hypoxic condition. Now, if it is still not treated, we give injection of MgSO4. Still not treated, we give him ipratropium. What was ipratropium? Yes, you guessed it right. It was the anticholinergic. Other anticholinergics? Yes, Times of India, tiotropium, oxytropium, and ipratropium. Okay. Now, if it is not treated, now too, we give one preparation. What preparation we have studied in this lecture? Yes, aminophylline. Okay, this is modified theophylline. Now, tell me one thing. If he is not treated, so we give the last one, general anesthesia, and we keep him on ventilator. What will general anesthesia do? Bronchodilation in unconscious state. Okay. Now tell me one thing. We have seen that the patient came first time to your clinic. He was given formoterol and budesonide. Then if it is worsen, it is known as status asthmaticus. We give HHS therapy, humidified O2, then high doses of a beta 2 agonist, and we also give hydrocortisone, which is a systemic corticosteroid. If it is still worsen, we give MgSO4 injection. If it still worsen, we give ipratropium, the anticholinergic. And if it's still worsen, we give aminophylline. And when it is still worsen, we give general anesthesia and ventilator. So if in the second time, in the status asthmaticus case where we give the HHS therapy, if he or she suddenly decompensate, okay, so what we must give? Okay, suddenly decompensate. What should we give? So in this case, remember we have seen that the beta 2 agonists are given by oral route, subcutaneous route, by inhalational route, and by IV route. Remember? So two routes are important here, subcutaneous and IV. And we have seen subcutaneous which injections? Yes, terbutaline. Terbutaline injection are subcutaneous. And what was the IV injection? One injection I mentioned, yeah, salbutamol. Okay, and if in his decompensated stage, if we give this injection and if it still worsen, we give him this general anesthesia and ventilator. So to sum up the management, at first the patient came to your clinic, okay, with asthma. We give him the SABA plus LABA combination formoterol plus one inhalational corticosteroid budesonide. If it is worsen or not treated, it is known as status asthmaticus. We give HHS therapy, humidified O2, high doses of a beta 2 agonist and hydrocortisone injection. If it is still not treated, we give injection of MgSO4. If it is still not treated, we give ipratropium, which is an anticholinergic. If it is still not treated, we give injection of aminophylline, which is a PDE inhibitor. Okay, it increases the CAM pathway. If it is still not treated, we give general anesthesia and we put the patient on the ventilator. And what will this general anesthesia cause is, it causes bronchodilation in an unconscious state. And if when we give the HHS therapy, okay, in the status asthmaticus, if the patient suddenly decompensates, we give him subcutaneous injection of terbutaline and IV injection of salbutamol. And if the condition worsens, we keep him on general anesthesia and ventilator. So this was all about the management of asthma in chronic state, in acute stage. Okay, so let me just mention, we have learned about the acute stage. Now the same patient, or the second patient, okay, one patient which is suffering from asthma since 1 year, and if he comes to you and if he complains that he is suffering from more attacks. So we have various stages, okay, in chronic stages. Okay, we have mild stage, we have moderate, we have severe, and we have refractory, and we have corticosteroid resistant stage. These are the various stages under chronic stage. Okay, so in mild attack means very less, 1 attack per day. Okay, we give inhalational corticosteroid in low dose. Okay, means in mild, 1 attack or no attack per day. Okay, we give inhalational corticosteroid in low doses. In moderate stage, 1 attack per day, we give inhalational corticosteroid. Let me write it, ICS, in low dose, plus we add a LABA. Okay, or what were the example in LABA? Salmeterol. Yes. Then in severe stage, we have the bedridden patients. Sorry for this today's handwriting. Bedridden. Okay, for bedridden, we give ICS, inhalational corticosteroid, in high doses and a LABA. Refractory. Okay, refractory means the next stage where not inhalational corticosteroid, not LABA is effective. Give oral corticosteroids. Okay, and corticosteroid resistant. The last stage we give monoclonal antibodies. Okay, now to sum up the chronic stage, so we have the stages mild, moderate, severe, refractory, and corticosteroid resistant. In mild means less than 1 attack or 1 attack per day we give inhalational corticosteroid in low doses. Now, in moderate, we have 1 attack per day, we give inhalational corticosteroid in low dose, plus we add a LABA. Then in severe, we have more than 1 attack per day and a bedridden patient, we give inhalational corticosteroid in high doses plus 1 LABA. In refractory, we give inhalational corticosteroid, we give oral corticosteroid, okay, refractory stage. And corticosteroid resistant, we give monoclonal antibody. To sum up the whole thing now, we first started with the definition of bronchial asthma, then we saw the pathogenesis, side by side we saw the drugs, the classes of the drugs, then we saw the classes in individual aspects, then we saw the management of patient of bronchial asthma in acute stage, okay, and in chronic stage. So that's it for today's lecture. Thank you.